medical director and founding director for, sorry, uh, is a internal medicine doctor, and then also has her PhD from the University of Oxford as a Rhodes Scholar.
So it looks like I always have trouble with this from the MedStar side accessing. It looks like you have it saved to a Google Drive.
Yeah,
The
I think
files
that yeah, the file's too large to send as
just an attachment. Okay.
yeah.
Let me send you my not MedStar email address.
Okay.
We'll get this going. We'll get intros, we'll get recordings, we'll get PowerPoints. It will all be amazing. So, and then just as a sort of one more thing to add into the mix today, we are, just as a reminder, recording these. So if you feel uncomfortable, but the plan will be to form a curriculum for IRB members in the future, but also for the Georgetown community. So let's see, where are we with getting Dr. Krishnan's PowerPoint? Jim, you're sending her another email address to do that, is that correct?
Yeah.
Yeah, and I just forwarded them.
Yeah.
Okay, perfect. Why don't I take 2 on the intro then, and we can move from there. And hopefully during that little piece of time, we can get the PowerPoint up and going. All right. So Lakshmi Krishan, as I said, is an internist, but also the founding director for the Georgetown Medical Humanities Initiative. She has faculty appointments in both medicine and English, and is a nationally recognized scholar of diagnosis and diagnostic disparities. She has done really impressive work on equity and in narrative around equity and inclusion in medicine. And we're really excited to have her today to speak to the IRB. So welcome, Dr. Krishnan. We really appreciate your time and energy. And hopefully we can get your PowerPoint up and running. If not, maybe we'll facilitate just an interesting conversation, because that would be good.
No,
as
we're
well.
good. It's up.
Yeah.
It's up.
See that?
And thank you so much. Thanks, James, if I may call you James. And thank you for that really kind introduction. And also, I apologize for the lighting and what I'm wearing. I'm on clinical service in the hospital right now, so I snuck away to find a quiet spot. As you know, the hospital can be a hard place to do that. So if my face is not super clear, I am definitely there, and I'm smiling, even if I look like I'm like in the shadows. But, I just want to thank everybody for this invitation, and especially thank Dr. Goyal, who reached out after I gave basically this talk, or a version of this talk, to our Georgetown medical student and faculty community, I guess over a year ago now. COVID time is such a strange thing. So it's just really, I don't often get to talk to this kind of group, so I'm really excited. I see some familiar faces. I'm going to try to talk for about 30 minutes. It may go a little bit under, a little bit over, but I also want to make sure we leave plenty of time for discussion and conversation. But really what I want to talk to you about today, I'm, as Erin was saying, I am the director of the Medical Humanities Initiative. I have graduate training, a doctorate in English literature, but where I really find myself now is as a historian of medicine and a physician. And so what I want to talk about today is why history of medicine and health equity are such critical partners. That really, this is a research collaboration as well as a humanistic one. The idea being that we can take insights from history, from the archive, as we call it, and use them to understand contemporary health disparities. And that we can only really change where we are to understand things like racism in medicine, structural and systemic inequalities, by delving deeply into historical causal pathways. So this talk was really inspired by work that I did during the beginning and middle of COVID, the COVID pandemic, which is obviously still ongoing, thinking about a case study of a different pandemic over 100 years ago, the Great Influenza Pandemic of 1918 and 1919, which is really a critical episode in our understanding of contemporary infectious diseases. Next slide, please. And then no disclosures, so onward. Perfect. So what I'm going to do is just discuss the scope of the problem even now in 2023, focusing on COVID-19 and health equity, but then drawing on both the scientific evidence base and the archive. I'll talk through historical burdens and causes of disparate health outcomes related to vulnerable populations, and then finally challenge us, and you as IRB, you are the kind of conduit for all the research that's coming through our institution. So thinking about how do we develop novel frameworks to apply a historically informed lens to the way we do research now and to improve health outcomes today. Next slide. So, this is a headline that struck me from the UK publication, The Guardian, back in April of 2020, that it's a racial justice issue. During the first months of COVID-19, as the early health disparities data started to emerge, showing how the pandemic was landing disproportionately on racial and ethnic minorities, chronically ill and disabled people, and the elderly, unfortunately, health equity folks who've been doing this work for a long time and historians of medicine found ourselves in conversations where we were disturbed, but unfortunately not surprised. The history of previous pandemics, or even the pandemics that have gone endemic, teaches us that pandemics always lay bare and always make more visible social and structural inequalities and health disparities that already exist. Next slide. So at the start of COVID, I was not yet at Georgetown. I was still practicing in East Baltimore at Johns Hopkins, a city and a place that's near and dear to my heart. I went to medical school there. I went away for residency and then went back for fellowship. So I got to know the city very well. And it's a city with a complicated relationship to this medical institution. It's at the very heart of a city that is, along very segregated fault lines, a city with profound income inequities. And so we were, thinking about and talking about how health inequities structured our clinical practice well before the COVID-19 pandemic. Next slide. Over the past 25 years, Baltimore has rarely seen less than 1/5 of its residents living below the poverty level. And that figure is well above the nation's 16% rate or Maryland's 10% rate figure. Next slide. And this is just, I actually don't know if it's going to allow you to do this, but oh, perfect. Great. So it's sort of showing, the spread of the city's racial and ethnic demographics, 1970 to 2010. And I think, this gives us the picture is worth 1,000 words, right? In terms of where folks live and how starkly divided and segregated the city is. Next slide. So this was a really valuable project that many of you may be familiar with. It was the COVID tracking project. I believe they stopped in the fall or the early winter of 2021. And, this is data from October of 2021 from that project, discussing how Black Americans accounted for 15% of COVID-19 deaths where race was known, and that Black folks have been hospitalized at 3 times the rate of white folks. Next slide. This is data from the CDC, which showed that Hispanic Americans have been nearly 2 times as likely to contract the disease as white Americans. And of course, that essential employees, those in healthcare, food services, transportation, other crucial roles, were much more likely, they had higher case fatality rate than other workers. Next slide. And Native and Indigenous communities have lost loved ones to the disease at more than double the rate of white communities. Native Americans have had 2.2 times a greater COVID-19 case incidence and almost quadrupled the death rate of white Americans in Montana. Next slide. So asking the question, what is affecting health outcomes for vulnerable populations? This has been preoccupying us, for years, and especially over the last 3 years of COVID. We have definitely seen with COVID-19 that pandemics are not exceptional events. They cluster with other burdens, so other infectious diseases, chronic and non-communicable diseases, disparities, income inequity, racism, et cetera, to create what is known as a syndemic. So many pandemics working together. So describing it another way, there are a number of specific factors contributing to that causal pathway, including, but not limited to, also different forms of bias, explicit and implicit, reduced healthcare access, lack of trust that's often rooted in historical causes, and an insufficient evidence base, missing data, which again, I think this is why it's so valuable to be able to talk to this group. Next slide. So here I'm quoting from Dr. Lisa Cooper, who's at Johns Hopkins, and Dr. David Williams' JAMA article, which came out in 2020 and is really a tour de force in outlining the current and the future problem while tying it to a history of systemic and structural inequalities. And I think that last line is of especial importance, which I've bolded, of particular concern. The number of excess deaths for Black Americans in the last decade of the 20th century was almost as high as in the first decade. I just want to make sure, can everyone hear me okay? Okay, I'm getting Teams messages from my clinical team at the same time. So I was like, oh my gosh, am I falling off? Or, okay, wonderful. So, right, that's the kind of line, we think about progress, we think about scientific advancement, technology. I mean, some of this has been absolutely amazing. When we think about even just COVID-19, mRNA vaccine development and rollout was incredible. I mean, let's not understate that. But then why have those numbers remained the same or similar over a century? And this is the kind of place where I think having multidisciplinary thinking about this, having historians, having epidemiologists, all of us in the same room is so critical, because clearly there's some piece that's missing. Next slide. So I'm going to now tie some of the historical roots and causes of these disparate outcomes related to vulnerable populations to those specific causal factors. Next slide. So unfortunately, the history of racism in medicine is part of our story, and we have to grapple with it to understand how we got to where we are now. And as I always say when I present this work, I was not taught most of this in medical school. And that just brings it really home, because I didn't go to medical school that long ago. So, this is not a different historical period. Some of you may remember this. This was a news item in the days pre-COVID in 2018. It's a statue of a physician, J. Marion Sims, that used to be in Central Park. And Sims has been lauded as the father of modern gynecology. Again, that's how I learned about him actually in medical school. It was only later as a historian that I learned about much more of his legacy. Specific medical tools, OB-GYN tools, the Sims forceps and speculum are named for him. And now this has really come to the fore, but many of his gynecologic discoveries were made through repeated surgeries performed on enslaved women, 3 of whose names we know, Lucy, Betsy, and Anarcha. And in numerous instances, these were done without anesthesia, even once ether became available. So when Sims started, ether was not available, but then when it became available, he didn't avail himself of that in the interactions with these specific women. But I want to be clear, Sims was not some monster who was out of his time. He was not exceptional for his time. Part of his justification, and we have his memoirs in detail, was that he was actually helping these women, quote unquote, and also that Black patients' bodies experienced pain differently or to a lesser extent than those of his white patients. And this was really in line with the racial and biological essentialism of the time, which unfortunately are concepts which carry forward. This study that I have quoted here, this is a 2016 study, so quite recent, in the Proceedings of the National Academy of Sciences, showing how a substantial number of healthcare professionals continue to have false beliefs about biological differences between Black and white and non-white patients, demonstrating how these beliefs predict racial bias in pain perception and treatment recommendation accuracy. So this history is very much alive. Next slide. So here is another historical example of bias in the late, and this is through the example of another pandemic. In the late 18th century, the city of Philadelphia experienced a devastating yellow fever epidemic, and the idea circulated that Black people could not contract yellow fever. So Benjamin Rush, a very respected physician, still on portraits and plaques everywhere and made incredible contributions to medicine, enlisted community leaders Richard Allen and Absalom Jones to call upon their fellow Black Philadelphians to care for their white counterparts after the white elites had actually fled the city. And once these duties were complete and once the outbreak eased, then many of those folks who returned home accused their Black neighbors, et cetera, of stealing from their homes. And in fact, Allen and Jones were so outraged that they issued this refutation, telling the real story of the epidemic and the sacrifices of the Black community from their perspective. What we find often with pandemics is that these medically and structurally racist ideas do gain more traction, as we saw in part in COVID-19. The yellow fever example is just one of many. There was the late 19th century US smallpox epidemic and its impact on those who escaped enslavement. There was cholera in 19th century India, which struck the native and indigenous people with far more virulence than the British colonial population. But the idea was that Indians were dirty and unkempt, and that's why they were, contracting cholera, as opposed to examining things like, at the time, right, water supply overcrowding and conditions that were facilitating its spread, as opposed to blaming specific people. There was the bubonic plague in San Francisco's Chinatown in the 1900s, which was also blamed at that time on Chinese Americans' racial inferiority and, quote, dirtiness. So these ideas, unfortunately, kind of resurface with pandemics, even if they're existing on a simmer at other times. So the idea that Black people were biologically different cropped up again during the 1918 influenza pandemic. And here I'm quoting some of my own work with Lisa Cooper and my friend and colleague, Michelle Ogunwale, who's at Hopkins. We wrote a paper where we looked at how biological immunity was used to justify new bias or existing racial bias. So there's an example of Chicago Commissioner of Public Health, J.D. Robertson, who actually used this argument to justify poor public health measures, especially in the minority parts of Chicago, as well as draconian housing ordinances leading to overcrowding. So we can see how all of these factors intersect: environment, urban design, essentially, redlining, a term that's become so much more familiar over the last few decades. All of these things set up factors that continue to operate today. And in fact, William Pickens, who is a major African-American columnist at the time, wrote on this subject, talking about how this bias cuts both ways in that quote, and that it conveniently entrenched mainstream economic and social power. Next slide. So I just want to, next slide, please. Thank you. I just want to briefly mention on the 1918 influenza pandemic. I think that context is important. It scorched its way around the globe in 3 waves over 1918 and 1919 toward the end of World War I. The total number of global deaths were estimated at 50 million, but were arguably as high as 100 million, though we generally think these numbers are an understatement. Next slide. The pandemic exhibited a W-shaped curve, unlike the more familiar U-shaped curve of regular influenza. This pandemic had a peak in young adults, 20 to 40 years of age. And part of what made it so horrifying was that the influenza and pneumonia death rates for young adults at this time was 20 times higher than in previous years. And the clinical syndrome showed some distinct features which were outlined in medical journals, such as this example from the Lancet. And these features created a special horror. Oftentimes, patients were cared for at home initially. And so family members were observing these signs and kind of charting them against what they knew was the progression of the disease. Next slide. When it came to the differential impacts of the pandemic in the US, based on the few databases that we have, which is a large life insurance study and some incomplete census reporting, there's actually this interesting situation where Black Americans who historically had always had higher mortality during pandemics actually appeared to have lower morbidity and more mortality than the white population during the fall of 1918, which was really the worst part of the pandemic. But they had higher case fatality than the white population, meaning that if a Black American contracted influenza, they were more likely to die. Now, there are some folks actually, including, I have to put a plug in. I have a mentee who's a really wonderful undergraduate student doing research in this area. She's a history major thinking about becoming a historian of medicine. And she's actually found data that contradicts this. So when this comes out, it's going to be a big deal in the field, because we've always cited this data that there was lower morbidity and mortality for Black Americans. But there are a lot of theories about why this might have been. Could segregation actually have been protective in an ironic way, and functioned almost as a quarantine? Did Black Americans who were often maybe more essential workers have earlier exposure and developed immunity and therefore didn't have that worse second wave? So lots of theories kind of floating around. Next slide. But I think what's really important here is that there was a mortality spike across the board, and there were a number of factors stacked against non-white populations, including some of the ones that I have outlined. One thing I want to highlight here is the role of hospitals and healthcare access. When they accessed care, we know that Black Americans received substandard care in segregated hospitals if they could even be admitted. So, quoting here from a really great article in the History Channel, actually, that not many hospitals accepted Black Americans, and those that did sent them to the basement for care. We have in DC our own Howard University Hospital in our own city, which started off as Freedman's Hospital, and that was one of a very small number of Black hospitals that existed at the time. So most folks ended up being treated in their homes by family members, or by midwives. And these cramped and difficult conditions also made it very hard to administer care across the board. Next slide. Unfortunately, can you actually go to the next slide? I thought I'd skipped this one. Thank you. Unfortunately, the pandemic and social uprisings did not yield to improvements, but to further entrenchment of inequality. This is a 1937 map grading sections of DC and its suburbs using race as a criterion for investment in housing. So the lowest grades are those with the highest percentage of Black people. So these maps illustrate the shifting yet persistently segregated racial landscape of Washington, D.C. between 1940 and 2010. And they also exhibit the profound legacy of racially restrictive housing covenants, which legally reserved much of the city for white residents during the first half of the 20th century. And as I keep making the point, the wages of these covenants and redlining has shown itself in environmental health issues over the past century. Overcrowding, pollution, hazardous conditions. Black children have higher rates of asthma. And during COVID, of course, we know that overcrowding contributed to transmission and inability to isolate in vulnerable communities. Next slide. And next slide. Okay. So what next? What after painting this kind of dark history, the responsibility for solving these problems lies with us. And I have to say that what I have seen over the last 3 years has actually been, kind of agitation and movements across the board, medical education, research, et cetera, that really give me a lot of hope. And I just want to actually, for the interest of time and to make sure we have time to discuss in more detail, can we go ahead and skip ahead? Um, I'll let you know when to stop. Yeah, keep going. There we go. Thank you. So, as you probably saw, those slides going before that are some very specific examples of addressing things like bias, dealing with stereotyping, implicit and explicit bias, et cetera. But what I really want to offer here is a broader framework that we need intentional strategies, and that this is a place, of course I'm biased, but I think that this is a place where historical and narrative knowledge, in addition to our traditional biomedical and scientific research, can be so central and so important. People connect through hearing stories. When I think about what I learned, what sticks with me from my medical training, and still when I see patients, it's a certain story that then led to an exploration, whether I pursued research, whether it's just remembering a certain disease process, et cetera. But stories and narrative are across the board, I think, the ways that we start to learn as human beings. So I hope that in this talk, I've made the case that narrative knowledge, right? The knowledge that comes from patient and practitioner experiences, from the historical archive, from interprofessional communication, and then also knowledge that's hard to track down from oral histories traded in communities is really critical to our cause. So, I told all of these stories and I shared all of these histories, but something that really sticks with me when I was seeing patients in Baltimore was that folks just talked about the history of Johns Hopkins in Baltimore. They talked about what had happened to their grandparents or their great grandparents. This was not, stuff that could necessarily be tracked down in a formal archive or formal evidence base, but these were stories and oral histories that circulated and had real impact on how patients viewed that institution and viewed the healthcare system, being part of research, enrolling in trials, all of it. So I don't think we can discount the importance of that. So here, there's this idea of a framework and a toolkit. Number one, education. We have to move beyond cultural competency when we're training, researchers and clinical practitioners. History of medicine and bioethics and this context for our present challenges, I really believe has to be baked into our health professions curricula. And so when I teach undergraduate pre-health students or future historians of medicine or future epidemiologists and medical students about J. Marion Sims or about the US Guatemala syphilis study, most of them have not interacted with that knowledge before and describe it as career changing. Then there's the issue of the pipeline, right? History shows us how a number of factors, including the generally praised Flexner report, which overhauled US medical education, really decimated the pipeline for non-white and particularly for Black, Hispanic, and Native physicians in the US. So to reduce disparities, we need to diversify our healthcare workforce. We know from the literature that when doctors and patients do share cultural touchstones, care is improved. And of course, then those are folks who are also conducting research that is aligned with that mission. Patient stories and narratives are really central. Their on the ground experiences fill the qualitative gap, and they point out areas of research and intervention that we may not even be aware of. I also think practitioner stories sometimes go underappreciated. The encounter between patient and practitioner is really at the core, and we need to understand all the angles, including practitioner experiences, practitioner life stories. And finally, and this is my final point and probably my most impassioned one, there is a huge dearth of evidence still, qualitative and quantitative, on health disparities. And as research in this area develops, I am personally invested in this, and I think that this is what we have to do, which is the formation of multidisciplinary teams that engage a broad variety of perspectives, including history of medicine and public health, bioethics, medical humanities, alongside our more traditional teams with practitioners and clinical and public health researchers. And I think if we're ever to truly tackle these huge and really daunting problems, we need that multidisciplinary perspective to expand the evidence base. So obviously I could say much, much more, but I'm going to stop there. And I really look forward to hearing thoughts and to a discussion. Thank you.
Thank you so much for that. I really appreciate your time and energy and for you coming here. Does anyone have any questions for Dr. Krishnan? If not, I have some stored up. I guess, the thing that is top of mind for me is that we really, in this forum, in the IRB, try to speak explicitly and to set into place systems and practices that actively fight for equity and so and I think, like, despite our best efforts, I feel like a little bit like we're flailing, right? Like we're trying to put very practical things in place in the power that we have. Are there things that you have seen in your study of this or thoughts about this of active ways IRBs in particular can start to address these things? And because we have quite a bit of power in some ways over the research that's done, but what are the things we should be looking for? What are the things we could actually be doing? I know that's a big question, but I figured.
No, that's such a phenomenal question. And I'll be very truthful. I hadn't be very, very truthful and blunt. Please, no one hate me. But, many of us as researchers think about, oh, how do I get through the IRB or deal with the IRB, right?
We are
and
there
actually,
with you.
yeah, and when I even having the opportunity to speak to you, I thought, oh my goodness, like the IRB is just, when we think about research formation and the foundations, yes, you all have an immense amount of both, I think, power and responsibility. And I'm really, heartened to hear too that you're thinking about and talking about this. So it is a huge question. I think one place that I would start, because this is a challenge for me, even doing history of medicine research, which is not community-based participatory research, but it is, and I'm gonna cut off like a tiny piece of your question, Erin, and try to answer it, but is trying to think about, like, I mostly research folks who lived in the late 19th century, early 20th century. I have no way to track them down. It's very hard to think about who are community stakeholders, who are the voices that are not brought to the table, even in historical research. So it's a challenge to think about all research as being some form of community-based participatory research. But that's really what I am trying to do. That is not how I'm trained. And that's part of it. I think we're all trying to almost deal with the foundations and assumptions of our training. My training was to go and look for sources that exist in the same way that we think about research, developing sort of scientific research. We form a hypothesis and then we try to either, interrogate existing evidence or create it in the form of, a clinical trial, let's say. But I find that the challenge is, well, how do I still make this community centered? And sometimes that makes the research take longer. It's more frustrating. It's not necessarily going to, I'm not going to get a publication within the next year. It might take 3 years. So it's kind of moving around and circumventing some of those. But I would say, thinking about, obviously not everyone is doing so-called CBPR, but are folks thinking of those principles? Like, are there community members that can come and present and talk to the IRB? Like, are there other ways? I think about the MHRI as having such a large imprint in DC. So how do we engage and build relationships between MedStar Georgetown and then the community? I wonder, does any of that resonate? Is that some of the stuff that's come up?
Yeah, I think yes. Short answer is yes. So we've talked about how do we integrate really a community advisory board into the IRB.
Mm-hmm.
What does that look like, even from an equity lens? Like, that's asking somebody to give their resources, their time, their energy. How does that work with truly being fair compensation. This is not something they can, that, I sort of get to put it on my CV and I feel like I'm doing something good in the world, but that's from a place of being well resourced at baseline, right? So how does that work? And then I think some of the other thoughts that we've had are about even how do we start to collect information from our researchers in a way that isn't punitive. I mean, I think we've all been there where the IRB feels a little bit like a hoop you have to jump through, but how can we get it through? Like, we're collecting information to really see that even the folks that are participating and bearing the risk are the same folks that will reap the benefit, or that those are matched up over time. And how do you do that in a way that's, again, responsible with it, and hopefully educational for the researchers too. I mean, I think another goal that we've had is we don't want this to be just another thing you kind of have to fill out in your continuing review, but how do we make you think just a little bit about what impact your research might have and what populations are being affected? So
yeah, and I think that's a huge thing. If the IRB can continue to be reframed as something as part of your process to actually make your research better and more impactful. I'm actually part of a part of a study right now, which will be coming your way or coming someone's way pretty soon. Coming soon to an IRB. But we are actually talking about knowing that it's a rigorous process that it has to go to. So it's a project on diagnostic bias in working with colleagues in psychiatry. And we are thinking, almost anticipating the questions that the IRB will ask, but in a really useful way. Like, look, are we making this rigorous? Are we making this, generalizable beyond this, but not so generalizable that it loses its actual, value? So it's almost like the messaging around the IRB and the kind of PR of the IRB. I will tell you, yeah, I'm a fan. I mean, I think obviously I know the historical reasons why IRB exists, and I teach my students about it. Like, we need protections for folks, and that there are numerous things like the Nuremberg trials and the Tuskegee syphilis study, and all of these things that are in part the reason that we have this. So we shouldn't scoff at it. It's really significant. And so I think also that piece, like, I'm an educator, so I'm always going to talk about that education piece of having, from an early stage. I think some of these mindsets start forming when folks are in undergraduate, honestly. And so having undergraduates understand, like, you will interact with the IRB a lot, and this is why it's important, and this is why it can make your research better, and then sort of doubling down on that, for the medical students. Because I work with ethicists too in the medical humanities, including one who's involved with IRB stuff, that's just a part of our curriculum, and I think it's so critical.
Manish, I saw you popped on. Did you have a comment?
Well, yeah, I mean, you both said it very well. Dr. Krishnan, I wanted to thank you for coming. I know it's been a long time coming, and the talk is fantastic. It's so enjoyable and so important for our members to hear. I mean, everything you talk about is at the core of why we function and the principles in which we hope to and try to review our different protocols and kind of host our meetings. If you have a mechanism or a way to improve our perception in the world for how the IRB is received, we are all ears. But we've taken up quite a bit of your time on service at that. So I really want to thank you again for joining us.
Thank you so much for the invitation. It's been really wonderful.
Thank you.
I'll jump off, but be in touch anytime.
Okay.
Take
Thank
care,
you.
everyone.
Thank
Bye.
you.